Sensitivity and specificity are often correlated. I will introduce two approaches to model correlation between sensitivity and specificity in probabilistic analysis. I will introduce some basic concepts through an example. This slide showed the distributions of the HVPG, a pressure test, for the people with or without bleeding. The test is not a perfect test to diagnose this disease condition, so the distributions of HVPG levels for these with and without disease overlapped. If we change the discrimination threshold, both sensitivity and specificity will be changed simultaneously. These simultaneous changes of sensitivity and specificity by threshold can be presented in ROC curve. ROC curve presents the performance of a test. An AUC of 0.5 means no discrimination. An AUC equals 1 means perfect discrimination. The higher value of ROC curve, the better test performance. With increasing discrimination for patients with and without the disease condition, the AUC will increase. We now summarize the implication of ROC curve. Sensitivity and specificity are often correlated. If the true positive rate increases, the false positive rate would increase, too. The cutoff threshold may be implicit, such as diagnostic imaging, but the threshold generally exists. There was a publication to discuss the optimal threshold, but we will not elaborate here. I introduce the first approach to capture the relationship between sensitivity and specificity in the probabilistic analysis. This approach is based on a single diagnostic accuracy study. The NICE-Pheno report used this method. The diagnostic odds ratio reflects the performance of test, the higher the better. It was assumed that log, diagnostic odds ratio, follows normal distribution. The standard error of log, diagnostic odds ratio, can be calculated based on this formula. We also assumed that specificity follows beta distribution. Then, we can derive the sensitivity from diagnostic odds ratio and specificity. The sensitivity will change to reflect the overall diagnostic uncertainty and its relationship with the specificity. Meta-analysis results are often used as model inputs in the economic analysis. There are two commonly used diagnostic meta-analysis models, HSROC model and bivariate model. When not including the study-level covariates, mathematically two models are equivalent. They are different parameterizations of the same model. The bivariate model allows inclusion of covariates that affect sensitivity or specificity or both, while the HSROC model allows covariates that affect accuracy or threshold parameters or both. Therefore, when including covariate, two models would be different. For the bivariate model, the logit transformed the true sensitivity and true specificity are assumed to have a bivariate normal distribution across studies, and it allows the possible correlation between them. See the variance-covariance of logit true sensitivity and true specificity. If using HSROC model in meta-analysis, we can calculate the covariance of logit, sensitivity and specificity, based on the parameter estimates from the HSROC model. This slide showed the second method of simulating the correlated sensitivity and specificity for the probabilistic analysis. Firstly, we simulate the bivariate normal distribution for the estimates of pooled logit transformed sensitivity and specificity. Then, we transform back to get the correlated sensitivity and specificity. An example with SARS and R codes can be found in the publication by C and his colleagues. That is all I have for today.